Hi, I'm Ron Soler from San Diego. It is indeed a pleasure to be presenting at the NCBH Digital Education Series. And once again, I want to thank Dr. Walker for giving me this opportunity. This talk, I'm going to be talking about how we can improve and optimize balloon angioplasty. I have no conflicts related to this presentation. So in 1964, Dotter and Judkins demonstrated that atherosclerotic narrowings and occlusions in the leg could be dilated by passing tapered Teflon catheters over a guide wire. 10 years later, Andreas Grunzig began treating patients with peripheral vascular disease with a polyvinyl chloride balloon he developed. And he concluded that this is a simple procedure and a relatively easy way to recanalize the pelvic arteries. And for 40 years now, balloon angioplasty has been used to open stenotic and occluded segments in the vasculature. Stents and drug devices were designed to improve outcomes of balloon angioplasty. So then, why do we need to optimize this? Well, lesions are often multiple and diffuse. Plaque and arterial resistance often prevent stents from being expanded to their expected size. In-stent restenosis is very difficult to manage often, and calcified and fibrotic plaque burden may impact drug delivery. And there still remain questions of drug-coated balloon and paclitaxel-eluting stents with respect to very late mortality. But perhaps a more important reason is that balloon angioplasty is very easily repeatable. So how do we do this? In the clinical use, we see only the lumen of the vessel. And so many people still think that we are compressing plaque into the vessel wall. Well, this is not correct. The mechanism of balloon studies was elucidated in very number of early studies, and it showed that the mechanism involves plaque fracture and subsequent stretching of the vessel wall. So while it is important to note that the inner lumen of the stenotic segment is dilated to the diameter that is adjacent to the normal vessel. So in other words, you dilate the inner lumen to approximate the diameter of the normal vessel. Note that the outer diameter actually increases dramatically, and this results in significant stretching of the arterial wall. This stretching of the arterial wall results in vascular injury. However, angioplasty itself is a controlled injury, and you need some sort of injury to make it work. And this was also noted very early on by Andreas Grunzig. Too little, and you'll have elastic recoil, and the vessel will result in restenosis. If you have too much injury, you'll have significant neo-interwall hyperplasia, also leading to restenosis. Studies of smooth muscle cell at the University of Pennsylvania showed that injury was not a function of the magnitude of the applied stress, but rather how fast the cell is deformed by the applied stress, a concept we call strain rate. And due to the fact, this is due to the fact, I should say, that the cell is viscoelastic. The membrane of the cell is viscoelastic. In other words, there's a time element. Now, there's a very nice way we can demonstrate viscoelasticity. And this is a child's toy, Silly Putty. I just happen to have some with me. Silly Putty, if you remember with your children, or if you still have your own, like I do, is a nice viscoelastic material so that if you pull it slowly, it stretches and stretches. But if you pull it quickly, it just tears. This is the same thing that happens in the arteries. We demonstrated this in a study in normal pigs' arteries, where we took a balloon and slowly and gradually inflated the balloon to its nominal pressure. In doing so, the lumen expansion resulted with no vessel injury. However, when we took the same balloon and rapidly inflated it to the same nominal pressure, there was extensive dissection and vasoconstriction. To improve balloon angioplasty results, there have been a number of investigators that show that slow, gradual, and long 3+ minutes at low pressure inflation protocols resulted in better acute outcomes. From the PTA control arms of the drug-coated balloon randomized trials, we've learned that outcomes are better when the vessel is first pre-dilated with a smaller balloon. And this is actually another way to gradually dilate. For example, in the pacifier trial, pre-dilatation in the drug-coated balloon cohort was 2 times that in the PTA control arm, and there were significantly fewer dissections. In contrast, pre-dilatation was equally performed in both arms of the IMPACT SFA trial, and there was no difference in the dissection rate in that trial. Since the vessel behaves in a viscoelastic manner, balloon inflation time would be expected to have an effect. In a prospective randomized trial of short versus long inflation time in infralingual balloon angioplasty, a 3-minute balloon inflation resulted in significantly fewer major and minor dissections, less need for further intervention, and the reduction of residual stenosis. However, in peripheral arterial disease, plaque morphology and composition are quite heterogeneous, and this often leads to inadequate, unpredictable angioplasty results. And this is especially true in complex lesion morphologies. So for example, we have a very hard calcified plaque that prevents the balloon from expanding in the vessel. We increase the balloon pressure higher and higher and higher, and then finally, at very high balloon pressure, the plaque cracks. And in doing so, the balloon has all this pressure there. It goes immediately to its full size. And like an explosion, this results in a very high strain rate. And often you see very severe dissection and excessive vascular injury. So sometimes we need a little bit of help. You need some help so that you can break through this plaque. And one way you can do this, of course, is by debulking. And you can debulk with a number of techniques. You can choose to cut, grind, vaporize your way to reduce the plaque burden. And there are quite a few devices available. All have shown to work quite well. You can also crack the plaque with shock wave to change the compliance of the lesion. And this is also shown to be very effective. Or you can take a much simpler approach. And that is, you can use a stress concentrator to fracture the plaque at low inflation pressures. And this approach would be to use a focal force or scoring balloon to provide the stress concentration. What's important, though, is to break the plaque before the balloon is fully inflated, and then slowly stretch the vessel wall. So a very simple illustration of this stress concentration is shown in this slide here. Say we inflate a balloon at very low pressure within the lesion. The pressure acting on the plaque is proportional to the force applied from the balloon divided by the area of contact of the force. Now, if we place a small wire alongside the balloon and apply the same force, that is, inflate the balloon to the same low pressure, because the area of contact is so much smaller, the pressure acting on that spot is significantly higher, and perhaps high enough to crack the plaque at its low inflation pressure. Using a buddy wire is a very simple way to concentrate the stress, and this was first reported in the early 1990s. But today we have a number of focal force balloons and devices available that can improve outcomes in complicated cases, and whether facilitating delivery of self-expanding stents, doing vessel preparation for drug-coated balloons, or used as a standalone to provide efficient and effective economic solution for treating peripheral vascular disease, these balloons are very, very effective. Here's an example of what you can often achieve with a focal force device. This is a diffusely diseased artery that was dilated with a long vascular balloon, slowly inflated to only 3 atmospheres for 3 minutes. And you can see the stent-like result often required no further therapy. And this technique is commonly seen despite what type of focal force balloon you're going to use. You can see these kind of results. Even in very old calcified vessels, focal force angioplasty can produce some very amazing results without the need for debulking. So in conclusion, my take-home message is balloon angioplasty works by cracking the plaque and stretching the vessel wall. Injury is a function of how fast that vessel stretches, so use slow, gradual, low-pressure, long inflations. And I can't emphasize that enough. And if you have complex resistant lesions, debulk or use focal force techniques to crack the plaque at lower pressures, and this will allow you to slowly stretch the vessel to improve outcomes. So as a reminder, we can think about the Simon and Garfunkel song, the 59th Street Bridge song, that tells you to slow down because you're moving too fast. You got to make the morning last. I'd like to just modify that slightly and suggest you slow down so you can make the plasty last. Thank you very much.